advocacy or alliance development team. So if there's anybody here that this is their first coffee chat they're joining for, we really hope that you will introduce yourself and kind of get to know the group. And hopefully folks will, feel free to be on camera, weigh in with your questions at any point in time. I'll introduce speakers here in just a moment. And we really do want to make this a conversation. So folks, we do want to hear from you and share your insights, your thoughts, your questions. So great. Thank you, Mike Knappen. This is your first. Welcome. So we'll see you when you get on camera. Carl, it's good to see you. I saw your email announcement yesterday about the U.S. courts pulling back. So do you want to share just a quick update on that? I think that's really exciting news, and your organization really spearheaded the advocacy around it. So
yeah, thanks. Good seeing everyone. Happy New Year. Yeah, the U.S. government, had appealed our court victory on copay accumulators, and yesterday they contacted us and said they were going to withdraw that appeal. So that is good news, but there's always a but, right? And but they said they're not going to enforce our court victory, and maybe they'll change that. I don't know. They're under a lot of pressure, thanks to a lot of you all. And but also the states can enforce it, and individual people can go to their plans and say, hey, the court says the copay assistance must count. So I think we will, and then we're still waiting for guidance from them. That would be really nice. Now we have an appeal as well, and we have not withdrawn that, so we're still contemplating what our next steps are going to be as well. And then, of course, this will help impact the legislation on the Hill as well. We need to solidify this, and we still have to close that non-EHB loophole, and because they're doing more and more maximizers. And so, hopefully the administration will move on that issue as well. It's some signals that they have looking into this in the notice of benefit and payment parameters rule. But we don't know what plans that applies to. We really want to apply that to the large group in the ERISA market as well. So good news.
Great. Well, hopefully we can feature that topic on a future coffee chat. So why don't we jump right in? We have a critical mass. Like I said, 130 folks have signed up, so we'll start to see more folks coming in. I'll start off. We're going to go ahead and put people's biographical sketch in the chat, so we won't spend a whole lot of time going into the backgrounds of each of our speakers, but start off with Patrick Clues, who is our Vice President for State Government Affairs here at BIO. He and I worked together for a number of years, and I know he is very much a thought leader in the state government affairs world from an industry perspective, and I know works with many of you at the state level. So Patrick and I will kind of co-lead the conversation today, and we are joined by three wonderful patient advocate speakers, but again, would love to hear from all of you. Just going in alphabetical order, Sam Cox, who is the Associate Director for State Advocacy at National Psoriasis Foundation, coming from Western Kentucky. Welcome, Sam. Melissa Horn, who is very much also a thought leader in this space and talked with Patrick at our patient summit and has been active on a number of different issues, including PDABs, which we're going to spend quite a bit of time talking about, prescription drug affordability boards. And Carter Steger from the American Cancer Society Cancer Action Network, hailing from New Hampshire. And again, somebody I've had the honor of working with for a number of years. So we'll kind of jump right in. What I'd love to be able to do is just have each of the patient advocates, starting with you, Sam, just talk maybe for just a couple minutes. What are your state priorities this year? Kind of what are you hoping to achieve? And then we'll transition to Melissa and Carter, and then I'll hand it over to Patrick to talk about probably pulling together a lot of what you all will likely be talking about and BIO's priorities and where those overlap, and we'll just have the conversation from there. Sound good?
Sounds good. Thanks, Michelle. Thanks for the opportunity again to be here. I really appreciate the opportunity to have this discussion about the opportunities and challenges this year. First, let me say the National Psoriasis Foundation, our goal really is to anticipate and respond to the needs of our community. It's really about bridging the gap between the initial need of an individual for treatment or medication, and then how the space and time between that need and when they realize the benefit of that treatment and medication. And that's really three large policy areas that we work on, various ways to go about each one, but that's access to a provider, which is not always a given, especially for a specialist. That's access to the medication or the treatment, and what hurdles can be encountered there with step therapy or utilization management. And then once they get that access to the provider and to the medication, can they afford it? And then once they initially afford it, can they continue to afford it? You know, we know in the psoriatic disease community, these are chronic. And so this is not a one-time thing. So when addressing that goal or trying to achieve this goal, there's many things that we're watching this year. Paramount of those are step therapy and utilization management. That's kind of our flagship issue, and we're watching that closely, not only to pass new laws in new states, but to go back and see where there's opportunity to optimize implementation, which we've noticed is a bit of a challenge. There's a few states where we're having conversations with insurance commissioners on how education and implementation can be better. We're working on copay accumulators, of course, but as Carl shared, you know, that's a great victory there, but certainly a need to regroup and figure out next steps as we await guidance on that. We're watching PDABs very closely. I know you mentioned that. We think there's a lot of opportunities with the PDABs, but equally there are some challenges as well. Nothing tangible on this, but we're watching how artificial intelligence can we don't want that, affect the healthcare space. We're looking at that, and PBM reform. We're big on share the savings, rebate pass through. We think that there's a lot of levers to pull in PBM reforms, whether that's, you know, spread pricing or anti-gag clause legislation, share the savings, of course. So really a whole host of issues that we're watching, and of course, always flexible and ready and willing to respond to whatever policy challenges our community faces.
Great, thank you so much. Melissa, for Arthritis Foundation, let's turn it over to you.
Wonderful. Well, first of all, thank you for having me on this distinguished panel. I have worked with Carter in the past in my role with the American Cancer Society. I feel like we're all kind of nonprofit tango artists. And we always represent such great causes, working for patient communities. And in my role with the Arthritis Foundation, I represent over 60 million Americans that are living with arthritis. And a lot of our goals mirror what Sam has already mentioned. But I will say, you know, our work with copay accumulators, for example, we're part of the All Copays Count Coalition nationwide, leading in that with the state effort. We have 19 states, DC and Puerto Rico. We'll continue efforts. I think we have like 16 states on the agenda this year to codify that law in place to restrict programs that wouldn't count copay assistance towards the deductible or out-of-pocket max. So certainly health coverage issues across the board is a top priority for us. Secondly, related to step therapy or prior authorization, of course, that fail first issue with utilization management protocols is a big issue for our patients. On average, from surveys that we've done, it takes 2 to 3 drugs for a patient to become stable that is living with arthritis. And we know that those drugs can be super expensive as well, but the burdens in just navigating getting their prescriptions filled is a big hurdle to overcome, especially when it comes to, again, the step therapy protocols, but also prior authorization, how long they have to wait before what their doctor prescribes is carried out and they're able to fulfill their order. So that those 2 issues, the reform around those issues, were part of the State Access to Innovative Medicines Coalition nationwide, and we'll continue to work. I think we have like over 30 states that have laws that have addressed reform to reduce the burdens of those 2 areas and other out-of-pocket costs related policy. So I urge you all to check that out. And then the last category, we've really partnered with the American Cancer Society Cancer Action Network on biomarker testing. So it's not just about utilizing labs, biomarkers, tissue samples, urinalysis, blood analysis to diagnose a patient. It's really about precision medicine to ensure that patients are getting the right dosage, the right treatment at the right time. So when it comes to arthritis, again, a lot of our patients have to go through multiple drugs to find the one that fits. We can reduce that kind of trial and error That is a huge win in our book and certainly for our patient community. All of this surrounds our overarching priority nationwide to address an ideal model of care. So really having patient-centered care, whether that comes to affordability issues or access issues, is our main concern for 24.
But thanks so much for sharing. And, certainly those of you who are online can read in your bio sketch, the story very personally, and just so appreciate your advocacy as a cancer survivor and your willingness to share your story. I think that that kind of courage and inspiration really helps, really motivates all of us. So, and with that, I'll turn to your colleague at ACS CAN, Carter Steger.
Hi, everybody. So happy to join you this morning. And I'm really pleased to be on with my fellow panelists who we work so closely together and work with many of you on all these important state policies. Want to do a shout out to Carl and thank you for your advocacy around copay accumulator. As said, we are going to continue our work, looking at what the impact of yesterday's decision by the administration will mean for copay accumulator, but we're involved with quite a few states, so we're pursuing state legislation. We'll continue that until, I think, get the guidance telling us it's not needed. The American Cancer Society Cancer Action is really network is really committed to making sure that the people we serve, those trying to prevent cancer, survive cancer, and who are going through treatment of cancer have adequate insurance. So we're, fighting off some bad Farm Bureau plans already. We're continuing our work to expand Medicaid in the states that haven't expanded. And this week, a report was released by the American Cancer Society that again shows that people who have insurance and people in states that have expanded Medicaid do better than people in states that haven't expanded, and people who have cancer. So cancer, having insurance matters to cancer outcomes, and we're committed to making, seeing that goal through of getting every state to expand Medicaid. It's really important for our work. And then, as Melissa mentioned, we're committed to our work around biomarker testing and appreciate all the support from the groups on the call. This is why we are, exactly what Melissa articulated is why we're committed to making sure that it's not a cancer-centric bill around biomarker testing, and that we remain, neutral on, all the disease, the disease states that biomarker testing will cover. I'm sorry, I'm getting visited by my colleague, my cat. It's so important. We know that cancer patients have, comorbidities, other diseases that they're fighting while they're fighting cancer. So it's really important that we make sure that it's not a cancer-only bill, which we've been asked to make deals on, and we've said no to date. And thank you to all the help from you all who've helped us articulate the need for that. We're also really upping our game around patient medical debt and reducing patient medical debt that's incurred while being treated. And so we'll be looking at practices around, debt collection and costs, but also our copay accumulator work falls here, as well as, trying to reduce copays in general. Our work around prior authorization step therapy. We're also going to be doing some more work around improving oncology patient navigation and the availability of navigation while going through treatment and screening. And we will continue our work on palliative care at the state level, paid family medical leave, fertility preservation, and reducing the copays and cost sharing for cancer screenings across the screening tests continuum. We're also going to be working on appropriations. This is kind of our mainstay for state cancer research programs, state cancer registries, state cancer plans, transportation and lodging services, as well as policies to help people stop smoking, especially getting cessation help, and policies that would prevent kids from starting, as well as our work around removing menthol and all flavored tobacco, all flavors from tobacco products. We have a vast agenda, as you can see, but our state staff, we work very closely with our state staff to make sure that we're setting an agenda that makes sense for the state and that's doable based on, the climate of the state. And we're committed to putting, our resources and staff time behind that. Before I close, I did want to just mention that the American Cancer Society today released the 2024 Facts and Figures, Cancer Facts and Figures, which highlights some important cancer trends and progress. We are seeing a trend of younger patients being diagnosed with cancer, and we're trying to figure out what we need to do to address that. Again, I just want to express my gratitude for being part of the panel this morning, and I'm happy to take any questions. And if anybody ever wants to just email me, questions or, requests for help, let us know.
Thank you so much, Carter. And you said so many things that are important, and one in particular, and this is sort of part and parcel of the patient advocacy community. And I know many of you are very steeped in the community. Some of you may be newer. I thought Andrew Sperling is on the call as well he has been with NAMI for so many years. When we were all fighting 25 years ago on the 6 protected classes, for example, it was so important that the patient community stick together. And oncology was always, certainly, as you mentioned, lawmakers want, they often want to make deals and sort of do kind of a special provision that supports one subset of patients. And you've always been so strong as a community across the patient groups, to ensure that sort of the rising tide lifts all boats. And certainly, definitely, I know that across the patient community, that's been a very important piece. So I've appreciated that so much. So with that, why don't I turn over to Patrick Clues, if you want to share a little bit about certainly yourself. And we have a mix of folks on the call today, mostly patient advocates, but a number of folks from our member companies. So Patrick, I wonder if you also don't mind talking a little bit about how the State Government Relations Committee works at BIO for context,
Sure.
and then talk about the priorities there. Thank you.
Great. Good morning, everybody. I see a lot of familiar faces, a lot of people I shouldn't say actually enjoy working with. That's sort of a backhanded comment. People that I really enjoy working with, actually. I've been on some panels with a lot of you, and you're very smart, very good at your jobs, and you make me look smarter when I'm on a panel with you guys. So it's good to be with you guys this morning. Again, as Michelle said, my name is Patrick Clues. I'm Vice President for State Government Affairs at BIO. I've been at BIO for quite a while. I'm going into my 10th year. Actually, I'm going into my 11th year at BIO. Running the state team. Prior to that, I was in industry. I worked for Wyeth Pharmaceuticals for many years, and I left Wyeth just before Pfizer acquired Wyeth, and then I went on to a smaller, mid-sized biotech company that is no longer here as well. It was taken over by Teva, but I've been in the industry since the mid-90s, so and I've been familiar with many of these issues that we've been battling with since then. So we have a State Government Affairs Committee at BIO. We call it our SGRC. And that's pretty much the main governing board of BIO. So I actually kind of have 2 of those committees. One is my voting members, and that's usually one person plus an alternate per company. And they provide me and my team with strategic direction on how to engage on a particular issue. And then we meet on a quarterly basis or on an ad hoc basis if there's a new issue that's popping up. And then I have what I just generally call my State Government Relations Committee, and that's really just a distribution list of over 100 people. It's multiple people from the same company. It's representatives from our state affiliates, where we get on a regular call and do updates of what's happening around the country on the issues that impact the industry the most. And then we have a number of company-focused work groups on specific issues. We have a work group on rare disease and gene therapies. I have a work group on vaccines. Unlike pharma, BIO engages heavily in the vaccine space, and all the vaccine manufacturers are members of BIO. I should say all but one right now are members of BIO. And that's kind of how we're set up. I have a team of 5 regional people around the country. Some of you may have worked with them. I've got Brian Warren, who works for me, who has the Western US, Lily Melander, who covers the Midwestern third of the country, Laura Shrebnick, who reports to me and has the Southeast from Maryland down over to Mississippi and Alabama. And then Steve Byrne, who just joined BIO in October, who has the Northeast, kind of this cutoff is New Jersey, Pennsylvania, and North. And then I have a gentleman working for me who's based in Washington, but handles all of our ag issues. And he covers all 50 states. So we're a small team, but I think we are effective for our size. A lot of the people that work for me, I've purposely hired because they have significant experience in government affairs and in the industry. So we're a good team. I like to say we're small but mighty. Obviously our goals, I kind of put things in 3 buckets. One is to ensure patient access to the therapies that our member companies research, develop, manufacture, and have on the market. The other goal is ensuring that our member companies have sort of a good policy and political environment to work in and to operate in. And then the other one is promoting growth of our industry. And that's a lot of the economic development issues we work on in many states to either grow or strengthen or build a biotech cluster in a given state. So, obviously ensuring patient access, a lot of issues fall into that. I think obviously the biggest one that we're dealing with are all the various flavors of prescription drug pricing legislation. And I think a lot of people had mentioned PDABs. That is our biggest threat right now, and that issue seems to grow. We have bills introduced this year in, I'm just looking at my list. There's 2 carryover bills, one in Pennsylvania and one in Michigan. Hopefully they're bottled up and won't move. We do have a bill in Virginia, a bill in Vermont, a bill in Wisconsin, a bill in Nebraska. And then we could potentially see a bill in Maryland to expand the PDAB already in Maryland, as well as a bill in Oregon to expand in Oregon to give that PDAB UPL authority. And there may be some other technical correction types of legislation as well. I understand that there's a draft. I don't know if it's been turned into a bill or if it's still a draft in Colorado that codifies a carve out for rare disease therapy. So we're very active in that issue. Not just when the legislation is going through, but also engaging on the implementation process as well. But I'm sure you've all heard, Florida was the first state to have an importation plan approved by the federal government. I think there's a lot of hand wringing around that, but I'd like to put this issue in a little bit of perspective. I think people have to be mindful that Florida still has a number of hurdles they've got to go through in order to bring in the very first product into the state. They've got to get additional approvals on labeling and testing of drugs. It's only impacting a small segment of the market in Florida, pretty much the public sector, state employees, retirees, Medicaid. And then the Canadian government's not going to just let this happen. I think there's a very serious and concerted effort in Canada to restrict the flow of medicines from that market down across the border. So I think obviously we're concerned about it. I would say this is a deprioritized issue for BIO because biologics by federal laws are exempt from any importation schemes. However, it is something we are taking, we're monitoring, and we are in lockstep aligned with pharma on their positioning in this. We do not think this is a good idea. We think this presents some dangers, not only to the industry, but more importantly to patients who have the potential to get adulterated or tampered products. And we don't think that Florida or any state's going to have the capability to ensure that safety. So it is problematic. And because of this, we've seen a little bit of an uptick in states introducing importation bills. We have a bill in Virginia. We have a bill in Ohio that was introduced last year that has a good chance of passing this year. And then we have a bill in New York. So we'll see how those go. I do think, and in reading a lot of the the political rags about this issue. It does look like it really is a political move more than anything, a political messaging move, but we will see how this implementation goes. I think one of the more sinister things that's tangentially related to importation is this idea of foreign price referencing. We saw this attempt at the federal level. There are attempts at the state level too. We have a bill in Florida again. Florida's turning out to be a bit of a challenge for us this year, but we have Senate Bill 1750, House Bill 1431, which is a foreign importation reference, which is a foreign importation price reference bill. Once again, this is not to import the product, but to import the price control. And it is the language is kind of wishy-washy because it says that the state will look at countries that do not have a single payer system, but that are at least 20% of GDP of the US. And people are trying to scratch their heads to figure out which countries fall into that. And I think anecdotally, we did an internet search. Azerbaijan is one of those countries. So I'm sure that, Florida residents would really like the Azerbaijani health system imported into Florida, but we're going to do a little bit more digging in that. Unfortunately, that bill has some legs. I mean, it has the support of leadership in the state. So we are a lot concerned, I would say, about that bill in Florida. We're seeing an increased activity in 340B legislation. I know this is really not a patient issue. It really is sort of a manufacturer issue where states are trying to regulate the 340B program. This started a couple of years ago in Arkansas and has just sort of grown over the past couple of years. And it's really being pushed by community pharmacists and then federally qualified health clinics. They seem to be the constituency that are pushing these bills. We are in Carter, we work very closely with the American Cancer Foundation or American Cancer Society, I'm sorry, in pushing the biomarker bills. That's very important to us and their success and their implementation. The ACS CAN team has just been absolutely wonderful and very smart about moving this legislation in key states. So hats off to cancer. And we're really happy to partner with you guys on trying to push those bills over the finish line. And then, as I said earlier, we work with a lot of our state affiliates in pushing economic development plans across the country. And this could be anything from R&D tax credits, matching grants for the federal SBIR program to workforce development programs, things like that. So and then as I said earlier, we have most of the vaccine manufacturers are members, and the whole, as you well know, COVID and the COVID vaccine mandates have really caused a lot of, I shouldn't say caused, it has turned the issue of vaccines and immunizations into really a political football. And then you have people like Robert Kennedy Jr. running for president, who's really an anti-science, anti-vaccine candidate. And it's just added flame to that, or added fuel to that flame, rather. And we are working very hard to interject some sanity into this conversation to really push for strong immunization policies across the country and defend the science and defend the technology behind vaccines.
Yeah, definitely. Thank you so much, Patrick. Taking a step back, when we talk about PDABs, the prescription drug affordability boards, I think it'd be great to have a little bit more in-depth conversation. And we have had the recent case study in Colorado as one where a lot of the patient groups work together, and certainly Patrick, you and our colleagues in state government affairs from so many of the companies that are with us today also worked on it. So I think could I ask you, Patrick, to sort of define what is a PDAB and what is the intent of these PDABs? Why are they being created?
Right. The PDABs are really analogous to a state utility board where they regulate a utility price across a given state, but they have been established to get a group of people that sit on a board to look at the cost and value of the therapy. And if the board determines that the cost of that therapy isn't commensurate with the value, then they can impose a price. Well, they say it's a reimbursement limit. They don't say it's a price control, but for all intents and purposes, it's a price control. Not all PDABs have this price control authority, but a lot of them do. And in the legislation was really developed at the National Academy of Health Policy, NASHP, with we think the help of the Arnold Foundation, which have been very active in the whole issue of prescription drug pricing. They've developed this model language and it's starting to gain momentum. Maryland was the first state to enact a PDAB. I would say Colorado has been the first and most aggressive to actually start to implement the PDAB, but we're seeing implementation now in Oregon, which doesn't have UPL or doesn't have price control authority, but they are going to be conducting affordability reviews on a number of therapies. So in essence, it is a state board to rein in the price of prescription drugs. Part of the problem is, though, that a lot of the people that sit on these boards, there's very little patient representation, if any. There's very little clinical representation, if any, and very little manufacturer representation. And the board members seem to be slanted from the payer perspective for the most part.
And Melissa, I see you nodding. From a patient perspective, certainly all of us can appreciate affordability is a significant challenge. And I think that what we're observing is these state sort of boards are looking at a single number, not considering sort of the negotiation that takes place between manufacturer and the payer, number of things. But can you talk a little bit about what this means for a patient who's waiting for access, and how you sort of have thought about PDABs?
Sure. Well, it's been interesting participating in Colorado's process as they've convened, their conversations. First of all, I'll just say, again, these boards are appointed, and often the folks that are sitting on them don't have that direct patient experience. So it's very important for us. We haven't taken a position on the legislation to create them, but it's important for us, once they are created or as legislatures are considering them, to ensure that the patient voice is represented and their experiences. So often, those that are appointed don't have that firsthand experience. So a lot of these meetings are, very education heavy to let them know about what a real life experience could be navigating a really high cost drug, and all the barriers that go into play with that. Again, it's not just about these upper payment limits that, could be a legislative solution or a charge for these boards to consider. And I think the rare disease groups and the councils that have been created in several states are really helpful to emphasize that. The RDACs, the rare disease councils, those have been very instrumental. But just participating in Colorado, it's very cumbersome, the whole process. The meetings have been like hours long. It's a dedication of time, which is a significant hurdle for our patients who, again, are navigating a chronic disease. And, when they hear that the state is considering addressing a drug that they might be on, there's some anxiety that goes around that and their ability to participate in the discussion. So I know there's been like surveys, there's been one-on-one meetings, there's been group meetings in Colorado, and I think they're just trying to figure out the formula of what works. It's not that I think that the intention isn't there to find a solution. It's just that it's been messy to get the process rolling. And again, the focus on the scope has been so narrow, without a lot of representation from the patient community. So, in states like Vermont, we just submitted some commentary on legislation around the Green Mountain board that reviews affordability issues, both to the governor and the Senate committee, considering SB 98. Just did that last week, so fresh in my mind. But it's important to, again, consider that holistic approach of what are the factors that are contributing to the high cost. And it's not just what the price is whenever you go to ring up your prescription. There's a lot of other factors that come into play. And again, since we have a lot of cooks in the kitchen with a lot of different health plans, both that are state regulated and federally regulated, there's a lot of factors at play here of where can this board effectively solve this problem with just one solution on the table, or are they using it as like more of a checkbox? And we want to make sure it's not a checkbox if it's in play, the board is created, we want it to really look at, again, the whole picture, and address issues that are not so targeted again to, just the industry, but really looking at all the factors that affect cost whenever it comes to patient access.
Thanks. So a little bit of what's interesting about Colorado in particular, Patrick, you mentioned sort of NASHB and some of these, looking at Medicaid practices, but Colorado, as I understand it, is not limited to Medicaid. So I don't know, Patrick, or if anybody else wants to talk a little bit about sort of the scope of the Colorado.
Yeah, I mean, I think when you read the legislation and the statute, it's not specific in some instances, I should say, it's not specific on what plans are impacted. Like Colorado, we think the scope is broader. Maryland right now, the scope is pretty limited to state plans and county plans that the state has the purchasing authority over. But there are some states where it is pretty broad in terms of the market that it impacts. And we tried to do sort of some analysis of that. And I've got some slide deck somewhere that, based on our analysis, kind of breaks down what product or what PDABs we think, what's the scope of the PDAB. So it differs from state to state, I should say. Some states it's very limited to the state plan or the state purchasing plans. Others, it's more broad than that.
I'll open it up. Anybody who has questions for the group, feel free to pop those in the chat or pop your name in the chat and I'll call on you or speak up. So just know you can do that at any time. Carter, I saw your comment in the chat, so just wanted to come back to you mentioning the work that you're doing on PDABs and vaccines. And I don't know if you want to just talk about both of those a little bit.
Sure. So, we're, with Patrick, I should have mentioned it earlier, the cat distracted me a little bit, but, we are very concerned about bills that are, kind of rolling back vaccine the ability to protect people through vaccines. HPV vaccination is really important for cancer patients and the elimination of cervical cancer. But also, we do see a trend and some promising research around vaccinations in terms of treatment in the future, and want to make sure that we're protecting the ability of people to get the vaccines that need. Of course, COVID and flu is really, the ability to get those vaccinations is really important for cancer patients. And then, we haven't, similar to Melissa, we haven't weighed in yet on PDABs, but we're watching this very closely, having a lot of internal discussion, watching what drugs are on the list. And so far there hasn't been a cancer drug, but we are, we anticipate there will be at some point in one of the state, PDAB, boards, and we're trying to make sure that legislators know why it's not, why it would be detrimental to do that for cancer patients. And I do see this as potentially an area where we will grow our work, but more to come on that.
And if I could just chime in too, I think it's important to note, like Michigan, for example, and I agree, I don't think they're going to address anything till March. They've got to figure out their post-election November 2023, not 24 election, after they had some movement from state offices to local. But the governor there did initially make PDABs her focus last August, then kind of pulled back on them in like November. So it'll be interesting to see, folks on the state level. I look at states like Michigan or California or Florida, states that have national attention right now because of the 24 elections, where the governors are very active. If they mention specific issues, we always are kind of keep our eye on that policy creep. I know there's only a handful of states right now that again are looking at, new PDABs or amending their current PDABs, but again, we are really mindful of that additional attention on all of our issues. And we're trying to cut through the noise and really emphasize like media advocacy efforts to get patient stories out there.
Yeah, thank you so much. Sam, one of the first things that you mentioned when we kind of started with you, and you mentioned the focus that you have is really around provider challenges, or I guess network adequacy is sort of the technical term of being able to identify providers for patients. Do you want to talk a little bit about that?
Sure. Thanks, Michelle. First, do you mind if I mention something on our end about the PDABs?
Perfect. Perfect.
We do not have a position on the PDABs, much like Melissa, not on the legislation or on the actual administration of the PDAB, and states do vary significantly in how they go about that, both how the board's created, what's their criteria for drugs to focus on. And we have had similar concerns as Patrick and Melissa about patient representation. We have submitted comments though to, I think while they may be good intentioned, we want to be careful of any unintended consequences, whether that's an increase in utilization management. We know the psoriatic disease community, upwards of 70% have experienced this. We wouldn't want to support or encourage anything that could potentially increase that. Any changes to formulary mid-year. So we can't know what all would happen, but I think we need to be careful. There's always unintended consequences with any of these actions. We do see big opportunity though, while these boards are being set up for the patient voice. And that's why we try to get involved in it, is just to go before these boards, put patients before these boards, or on behalf of them, to educate legislators, give them some insight. You know, how can they be sensitive to the unique needs of different communities? They may not be aware of that. So the education part of that is crucial to us and something that we're very focused on, regardless of what ends up happening or how far they go or don't go. That's yet to be seen. And as far as a provider challenges, kind of what Carter focused on, Medicaid is something that we really focus on that matters a lot to our community. We've seen trouble, especially dermatologists in certain states. And so that's something we're digging into, is just being sure that in rural areas, especially, that there's access to providers. I know one lady who's a great advocate of ours, she was an hour and a half, 2 hours from the nearest dermatologist that was covered, and with her health conditions and just her family situation, it was hard for her to make it. So that's why we also focus on telehealth. We think there's great promise in telehealth. NPF did an internal survey a year or two ago, maybe more than that, during the pandemic, and found that there were overwhelming support from our community for telehealth, that they felt like their needs were addressed. They felt like they would do it again. And so those provider challenges, I think, sometimes are overlooked. It's a lot about affordability and access, which are also important, but the first stop is getting to a provider that can put you on that path towards the treatment that you need.
Thanks so much. Tiffany, you spoke up in the chat and had a lot of good things to share. Do you mind introducing yourself from AI Arthritis and kind of articulate a little bit more about what you posted in the chat, especially for anyone who might be just on the phone?
Sure, no problem. So thank you. My name is Tiffany Westridge Robertson. I'm the CEO of AI Arthritis, which is short for a very long name, International Foundation Autoimmune Autoinflammatory Arthritis. So we cover the 20-something diseases that are autoimmune or autoinflammatory in nature that include arthritis as a major component. We have been extremely invested in PDABs and also CMS listing sessions. We see a very strong parallel between the two in involving patient organizations, or in some cases lack thereof, because there's this sort of a new movement to getting what they say, quote unquote, real patients involved. And I live with axial spondyloarthritis, and all of the leaders of staff and volunteers at AI Arthritis are people living with these diseases. So we say we don't represent the patient voice, we are the patient voice. That's come to the forefront, especially with these PDABs and again, the listening sessions, when they're looking for people who have never really spoken, or they're saying that are influenced by others. And then patient organizations taking on somewhat of a different role in a kind of mentoring to get more patients and recruitment to get more patients, and not being able to speak if you don't have the disease yourself or haven't been on the medication. So it's definitely a different time in patient engagement, but an exciting time, I think. And so because of being an organization that's both a patient organization and people living with the diseases, and our whole mission is about identifying missing gaps, connecting the dots, and coming up with innovative solutions that have no blueprint, we're kind of like, hey, this is our wheelhouse, because the PDABs are like, what? Everywhere, right? So there is this element of navigating the unknown, and that's just totally our wheelhouse. So I wrote in the chat, there were 3 drugs of the 5 in Colorado for our diseases, and we were successful in making sure that we had representation in the listening sessions on all 3. So we are really proud of that. We also were very integral in getting patients to participate in the surveys, which have been reopened right now. They're open again till the 21st. At least there's 2 of them, and then the next 3 will open in the spring. But we, as people living with the diseases, recognized in the surveys that Colorado used, there were huge flaws in the designs of the questions. For example, there were 2 questions in particular that said, have you ever skipped a dose because of affordability issues? Have you ever spread out your doses because of affordability issues? And when that question popped up in the listening session I was in, I raised my hand and said, I am not able to answer that question as phrased. Those are 2 questions. And it's the same question that they have on the surveys even right now. The problem that's so flawed with that is, yes, of course I've skipped a dose. Of course I've spread out a dose. Has nothing to do with affordability. It's because of prior authorization. And so we made that very clear, and they listened. They realized, oh my gosh, this is super flawed. So I did hear from Callie and Lila 2 weeks ago that even though they had to use the same survey to relaunch because they can't mess up the data they've already collected, they are implementing all of AR Arthritis's recommendations for revising the survey next time around. And I also talked to Maryland PDAB last week. I sent them the recommendation letter and all of the corrections we made, and they're going to implement it. So they haven't created their surveys yet. So there's hope. And I just, they are listening. There are some PDABs that are better than others. And I'm going to say CMS too, because they are also listening. And there's this opportunity like never before to get patient organizations and patients involved. So I did, if anyone's interested, we are launching a national coalition called Ensuring Access Through Collaborative Health, or EACH. And it does have some elements of precision medicine and making sure we're not going backwards, and protecting the subgroups and all of those things, and qualities, all of that stuff that is sort of resurfacing as issues in these PDABs and CMS. And then we have a novel 2nd tier coalition that's just for patients called the Patient Inclusion Council. So
great. Good. And your name is very familiar to a lot of us. You really have also been a strong voice within ICER to ensure patient perspective. So just putting that out there as those of you who may be facing ICER reviews or therapies in your disease area facing ICER reviews, I really do encourage you to get to know Tiffany. She is not shy, and
I'm not shy. For those who don't know, so ICER started a patient council in 2023, and I am the patient co-lead of the patient council. So I have probably the most inner seat at ICER, and I'm very excited about that. And I do want to make sure everyone knows I am not a champion of ICER. I firmly believe that there are opportunities to evolve their processes, and they are very well aware that I am a huge proponent of precision medicine. And the first thing I said to them was, there's no such thing as an average patient. I'm not sure you want me. And they said, that's exactly why we want you, because you'll challenge us. So I looked at that as opportunity.
Yeah, that is great. And Sarah Emond, I think, has been, it's good to see her rising in leadership.
Absolutely.
I want to make sure that we talk about medical debt. Rebecca Kirsch from NPIF. Do you want to quickly just talk a little bit about what you mentioned in the chat, and share a little bit about NPAF for anybody who may not be familiar with your amazing organization.
Good morning. Thank you. I'm Rebecca Kirch here in Washington, D.C. And my position at National Patient Advocate Foundation is EVP of Policy and Programs. And the whole focus of our organization, the Patient Advocate Foundation, is on patients and caregivers who are experiencing financial distress as part of their, whatever their complex chronic condition is, every diagnosis. Carter mentioned how, we don't do trade-offs in legislation, pitting diseases against each other. And the partnership of us with all of you, I think, is important because we do represent all diseases, and it's a helpful alliance that we all share. So the direct patient services that our organization does is around helping people who are experiencing medical debt, financial distress, accessibility issues, affordability issues that impact their daily lives. So patients don't typically live in hospitals. They try to live in their communities. But even those who are insured are experiencing extreme financial distress because of cost sharing that occurs that we all know so well. So we provide direct services to help patients navigate to social supports and services for their daily lives. So while patient navigation helps you find your way through the clinical experience of care, financial needs navigation helps you maintain your daily life, your home, your food, your childcare, those aspects that are also important and impacted by disease and the expenses that accompany it. So I just wanted to raise or sort of highlight what Carter mentioned about medical debt and ramping up. I think that's something that is increasingly a problem, as I say, for insured patients, not just the uninsured. And the work in Medicaid expansion that Carter featured is certainly a shared priority, I think, for all of us, because Medicaid coverage is outstanding, especially compared to no coverage. So the importance of that in the state context, while we also think about how we can elevate tending to people's financial health alongside behavioral health and physical health. That was the point that I made, just that whole person care, person-centered care really revolves around all three of those aspects, which you can't tease apart. And I'll just give a shout out to Tiffany's work on ICER. I've been sitting on an ICER, the New England panel, for a few years. I have watched from the inside with trepidation, really, the open learning that ICER has tried to do, especially now with Sarah's leadership. I absolutely agree that they are very intent on learning from us rather than schooling us as patient advocates about how we can all work better to do better when it comes to the evaluations of what value means and thinking about it from that person-centered lens.
Thank you so much. Other questions or comments from anybody here? Anything related to state stuff at all, where to reach us? I'll make a couple of quick announcements, and that way that'll give you time to think about any questions or additional comments anybody here may have. So one is that I know in December, everybody has their holiday event and you're triple booked every evening and trying to get from one thing to another. So we decided we're not doing a December event. We instead are doing a Beat the Blues reception. So the holiday blues, which definitely for me personally have set in very much in full force, and we are hosting a reception for the patient community as well as the Alliance Development community starting at 5 p.m. on Thursday, January 25th, for those of you who are based here in DC. And if you're not based in DC, convince your bosses to let you come to DC. That will be in the Bio building, sort of in the atrium downstairs, and at the Bobby Vans down there. So hopefully we'll see you there. It's a really great opportunity to connect with each other, but also with your industry partners and maybe meet new partners. And again, hopefully this will become a tradition that we try to do something fun in January when everybody is, a little bit craving some excitement. Also wanted to just give you all a heads up. We will have a coffee chat 2 weeks from today, and that's going to be focused on the rare pediatric priority review voucher process, which I know is incredibly important to so many of you, both as manufacturers, but in the patient community as well. That is up for reauthorization this year. We really do want to make sure that that we are putting some pressure on Congress to ensure that that does get reauthorized. It has been such an important incentive for the development of drugs for rare disease in particular. With that, I also wanted to let you know we do, it's mostly for our member companies, but for everybody to be aware of, we do have a BioAction Alert right now, which is a grassroots phone to action campaign focused on research and development and some of the significant challenges that our small companies in particular are facing with regard to R&D tax amortization as well. So I will encourage all of you to tune in. We'll send you a link to today's coffee chat and share the email addresses as well for our colleagues who are putting those into the chat as we speak, so that you guys can network, get to know each other, and hopefully see each other at our event next week. But with that, anybody have anything they want to share as last words before we get back to our regularly scheduled Wednesday? Excellent. Well, say happy belated birthday to Jet, who now is not on camera. But we will share folks' contact information, and then we will also definitely be in touch. This has been such a robust conversation, Jess and Barrett, that Patrick and I have already agreed that we'd like to do this probably on a quarterly basis to really get our partner with our state partners. So thank you, everybody. Have a great day. Bye, everyone.